When it comes to peripheral artery disease and coronary artery disease, it really comes down to the health of our blood. To talk about the latest research and studies is Science Valley Research Institute's Dr. Eduardo Ramacchiotti and his esteemed colleagues. I'll let Dr. Ramacchiotti take it from here. Thank you so much, Dr. Ramacchiotti, for joining us.
Hi, Ken. How are you? Very nice to talk to your group. Hi, Dr. Ballard. Well, I'm a vascular surgeon. I was trained in the US, but I'm back to Brazil. So my company here in South America. And I decided, Kim, to bring Camila and Leandro because we could not identify a PAD patient association group in my country. So maybe after the discussions here, you might help us finding patients to plant a seed for patient advocacy group for PAD here. We have a country with 200 million people, 10 million with PAD in the country, and with a massive number of amputations, and we could not identify a patient association group. So maybe at the end of this discussion, you might be able to guide us in the reverse process of helping us creating a group like that in my country. How about that?
Yes, well, you ask, you shall receive. We now have officially started the Way to My Heart Brazil.
Really? Well, you should start something the Way to My Heart global. You know, it's not just Brazil, but we have in Latin America so many patients with peripheral artery disease. Yes. So let me jump to some slides. It's very simple. And Dr. Ballard, I would like to apologize in advance. I'm a vascular surgeon too. And of course, I place stents, I perform open surgery, but I'm quite convinced that the way to treat it is different. You know, maybe it doesn't make much sense to me to place a stent in an artery that suffers a metabolic disease. So we just fix the disease in the wall. I think in 20 years or 25, 30 years, we will come up with something less rudimentary like stenting our patients. Of course, I do that. But we're studying ways to prevent that instead of stenting our patients. And this is my disclosures. I work with so many anticoagulants. What we're doing, I think the number one study I would like to show that we're doing here, you guys are probably aware of the COMPASS trial that we published some time ago with PHRI folks from Canada, where we tested a tiny dose of rivaroxaban plus aspirin versus aspirin in patients with stable atherosclerotic disease. And we showed a reduction of major adverse cardiac events, cardiovascular events. We showed a cut in 50% of major adverse limb events, 70% less amputations, and to our surprise, 18% benefit in mortality. It's a pivotal trial published at the New England 2018, I think, but we never tested if this strategy improves walking distance in patients with intermittent claudication. And the guys who performed the COMPASS trial, they didn't test it. They were looking for hard endpoints. So we designed a small trial where we included patients with PAD with ABI less than 85 with intermittent claudication. And of course, we excluded patients who could not take anticoagulants, particularly with kidney disease or had previous bleeding or are using anticoagulants for atrial fibrillation or something like that. And we designed something very interesting. I think this is going to be helpful. We compared the COMPASS strategy to aspirin alone. And we used functional tests, the 6-minute walking test plus the treadmill test, and the baseline 3 months and 6 months. We just finished the study. I cannot disclose the results yet because we're in the middle of the statistical analysis. But I can tell you that we will come up with really, really interesting information for physicians who are adopting this strategy to treat clinically for the medical management of peripheral artery disease.
All right, I just want to stop you there just to clarify. So this is a study that you're basically saying you used pharmaceutical therapy, right, to see if just medications alone would help improve walking distance and reduce the claudication or when the cramping sets in.
Well, we learned that 100 meters or less, it's quite limiting to these patients. And differently from the US, where we have pretty much less resources here, we tended to treat these patients more clinically. We have resources to operate patients with ischemia or rest pain. But imagine a country like ours to provide such very expensive approach to treat PAD to 10 million people. We basically do not have resources. So we vascular surgeons in this country, we trend to be less invasive than my colleagues in the US, mainly because of lack of resources. And we're pursuing ways to improve walking distance. And as you are aware of, and all the patients here are aware of, by far the best treatment is physical therapy with a personal trainer. If you have somebody helping you out, walking and pushing you to walk, this is where you get better and you improve and of course, controlling smoking, diabetes, hypertension, cholesterol, and stuff like that. But in the past, we had cilostazol with very, very, very small improvement in walking distance in small trials. And when we published the COMPASS trial some years ago, cardiologists who started using this strategy, and it's not for all patients, they came to me and said, hey, you are the vascular surgeon of the group. How about you testing it for functional tests to see if the strategy improves walking distance? We don't have this data. So we run this trial in 8 hospitals here in Brazil. I just finished it. I showed to the main investigators of the COMPASS the results today, but it's super high level. And I'm not authorized yet to discuss the results because it's not clean yet. We're still cleaning the database. Statisticians are checking the baseline. But I think in 3 months, we'll have some interesting initial data to see if giving anticoagulants to patients would improve their walking distances. So now we're combining the benefit, if we're positive, of reducing major adverse cardiac events, major adverse limb events, mortality reduction, and amputations to improvement in walking distance. So if we're positive, it's a tiny, small trial, but it opens the door to have bigger trials in this very important indication. So we call it COMPASS claudication. The COMPASS folks who run the COMPASS trial are on the steering committee with me. They're helping me out in clearing the database, interpreting the data, and most important, since I'm still a professor in Chicago, we collected a very nice set of biomarkers for these patients as well, in a curve from baseline to 3 months to 6 months. And we just saw yesterday the results of the biomarkers. So I think in 3 months, we will come up with something new in terms of improving or not improving total walking distance in both the 6-minute walking test and in the treadmill test. So it's called COMPASS claudication. The study design is already published, and I expect to have this data disclosure in max 3 months. The other study that we're doing, and I think Dr. Ballard will also be interested, is testing apixaban after angioplasties below the knee. Really, really sick patients here, diabetic patients with ulcers, with ischemic feet. And what do we do in terms of medical management of them once we perform an angioplasty for these patients? By guidelines, we should give them aspirin and clopidogrel for 3 months, but we never saw any benefit in terms of reducing mortality or even reducing amputations. So given the fact that apixaban is a very safe drug for atrial fibrillation, we got a small support from Pfizer Global to perform the Agrippa trial, where we randomized infrapopliteal angioplasties to either aspirin or clopidogrel or apixaban 2.5 plus aspirin. So it's a strategy. We're checking if we could reduce the number of basically Mayo events after infrapopliteal angioplasty. We just finished some months ago the inclusion of the patients. It's a multi-center study here. We will have results by October this year. What I can tell you, I'm totally blind for the study, is that given the fact that these patients are really, really sick, and here in Brazil, we perform surgery when these patients have already ischemic lesions, the number of events is incredibly high. So we expect to collect some new information also for anticoagulation strategy after angioplasty is below the knee. We have some data from another trial called Voyager, where I'm a co-author as well, and we showed some benefit in terms of using rivaroxaban plus aspirin, and mainly in re-interventions and ischemic events, but we showed no reductions in myocardial infarction nor strokes because of the sample size. In this particular trial, we're looking for a specific group of patients which is below the knee angioplasties. It's called Agrippa Trial because we ran the Augustus trial in the atrial fibrillation, where we showed that apixaban was nice for patients undergoing PCI with atrial fibrillation. So it's a kind of cousin. Augustus, a Roman general. Agrippa is another Roman general who worked for Augustus.
So this is another trial in which you're trying to test. There are a lot of issues when it comes to treating people who have below the knee blockages, especially ones that have wounds that are not healing, that are on the foot or on the toes. And so what you want to make sure is you want to slow down the revolving door of treatments and delay, right? It's not a matter of if they're going to have another procedure, it's a matter of when. And you're talking about studying the different medications and which one might be better to help delay future procedures just with medical management.
Exactly. It's a small trial for us to claim something, any benefit in terms of mortality. But what we're looking at is exactly what you said, delaying reinterventions and maybe delaying amputations. So we're looking for medical strategies after the surgical procedure to reduce or to improve the time of reinterventions and to try to prevent amputations in these patients. So medical, it's a combined strategy. Sorry?
So with some of these medications, restenosis or that healing response that occurs with the body and the scar tissue building up, is that something that you're studying in this trial as to whether or not medical management can help with that? Or are we talking more about the potential for clotting?
Well, we're not, I don't think we'll be able to show any prevention of this inflammation of the stenting per se. Mm-hmm. But I think that this anticoagulation strategy probably prevents embolic events from proximal arteries. But I don't think we'll be able to show a reduction of the inflammation of the stenting as well. So our strategy is very pragmatic and very simple in terms of combining a small dose of anticoagulants on top of antiplatelet therapy.
Perfect.
It's, again, a small trial. It's all our small contribution here from South America. We have some American folks helping me out. Well, I was trained in the US, so I have the connections, but we're doing these trials in Latin America because we can dramatically decrease the costs. And we have the patients, and we have, most important, variety. We have fat people, we have Japanese, we have Black people, and we need to include different types of human beings in clinical trials, and Latin America is just perfect for that. Moving on, Ken, that's the mechanism we're thinking about it. So we have so many reocclusions after stenting these arteries that we think that there is a possible benefit of anticoagulation. And this is the kind of artery we're talking about for the Agrippa trial. We decided to include really, really sick people. We're finishing enrollment, and we're going to have data in October. And I have two more trials that I think they're quite interesting. It is approved in the US, a drug called inclisiran. You're probably aware of it. The commercial name is Leqvio. It's not approved in my country yet. And we're testing it in a massive program to show reduction of major adverse cardiovascular events. Because this the mechanism of action is very complicated. It uses a sense and antisense technology to block messenger INR that produces a protein that's not good to us called PCSK9. And ultimately, using this strategy, we reduce cholesterol. And we're testing in the Victorian 1 trial the hypothesis that this compound, on top of statins, once every 6 months, reduces mortality for patients who had myocardial infarction, stroke, or PAD. So one of the inclusion criteria for having an event is having PAD with ADI below 85 and intermittent claudication and documented atherosclerosis in the limb arteries. This is the Victorian 2 study, and I'm happy to say that I'm the top recruiter in the world for PAD patients. They invited me to do that because I have experience with PAD patients, even being in Brazil. And we'll start in September, the Victorian 1 study, where we're looking at this kind of benefit, even for patients who had never had an event, but with high cholesterol levels, with high LDL greater than 70. For the Victorian 2, it's 18,000 patients. It's a massive trial, 18,000 patients. For Victorian 1, the same sample size. So we're going to have maybe compelling results for this compound. And I'm the only vascular surgeon in this group. It's so many cardiologists in these 2 trials, but they invited me, and I will have the chance to look in details for the subgroup PAD patients in these 2 massive trials to see if we see any better benefit in our PAD patients. I'm very excited. We are also working here at Science Valley with new ways to prevent cholesterol with different mechanisms, even with vaccines. So I'm pretty focused in finding a way to help our PAD patients to manage this disease and avoiding surgery. And to complement my presentation, so we can further discuss the Way to My Heart extension here to Brazil, I will invite both Leandro and Camila to talk how our patients here are helping us in our trials. So Camila, please go ahead.
Thank you, Dr. Ramaciotti. Thank you, Kim, for the invitation to join you. And we are going to show you how we are involving the patients in our clinical studies. We really expected to have an association of PAD here in Brazil participating in these trials, okay? But we are going to show you the experience we are having now. Here at Science Valley, one of the most important values is to have the patients at the center of everything we do, right? That's why we have a program that is called Science Patients. And in the next slide, we will show you, Ramaciotti, can you change?
Sure.
Can you move? Oh, okay, thank you. And here we are showing you that using this perspective that to have the patient first, we are conducting patient-centric clinical studies. In this way, the role of the patients has shifted from participants to partners in the studies. In this way, we have patients participating in the study team. So they work with the researchers to the design of the study protocol. And then we foster disease awareness campaigns that are very important, especially to educate the general population about the importance to participate in a clinical study. These studies, they have a decentralized component. We use apps to collect patient data. In this way, we can promote that people from other regions, from far from regions, from these other sites can participate in the studies. And this is a way to optimize the participation of these patients because they need to go to the clinical sites less times than usually they have to, okay? And we also include patient-reported outcomes in the study protocol. And this is a way to to recognize under patient and their caregivers what are the meaningful outcomes that should be investigated. And the participants are also working in the dissemination of the results to the community. We have a first experience with endometriosis, a gynecological disorder here. And this is now our standard to plan and to conduct the clinical studies. In the next slide, I think Leandro is going to invite you and how we can connect, right?
Definitely. I think it's so important. I see this trend in terms of inviting patients to be a part of the actual design of the studies. And I think that's really important. I'd like for you to touch on that again, because several patients here want to get involved. They want to help define the future of PAD treatments, be a part of the next generation.
I'll take that one, Ken. What we're learning is fascinating. Because sometimes we are physicians, and I never experienced a PAD event in myself. So when we bring these folks to discuss the trials, to discuss the endpoints, our question to them is, does it make sense to you as a patient? And to our surprise, they always come up with really good ideas. And most important, if we have a patient association like yours involved in a clinical trial, you help us in keeping those patients on the trial. It is too important for us that the patient doesn't give up in the middle because the neighbor came with a new idea and say, hey, forget this compound. We have a super thing new in the internet. So if we have a patient association helping us out with the retention, then we have less dropouts, and patients are helping us interpreting the results of the trials. And as Camila pointed out, we're now having patient-reported outcomes, not just what we're seeing on the CRF, on the clinical recording file, but reported by themselves. It's a new experience, and we're quite enjoying bringing patients to the steering committees. And most important, if they're really active, there will be co-authors in our papers, which is, I think, it's a legacy for people who are suffering with such a horrible disease like PAD.
Yes. And I believe Leandro is going to tell us how patients can actually get involved with the Science Valley Institute to find out what trials are going on.
Mm-hmm. Thank you, Ken. Hi, everybody. Thank you for the invitation. It's very nice to participate in such a wonderful event. As the CEO of Science Valley, we, as Camila said, we are investing a lot, resources, and all our tools are towards patient centricity. We have no doubts that if we come with all the tools to provide patients to give us all the feedback that they have during the journey in a clinical trial, this is much more valuable for us when we are going to have all the endpoints results. So as Eduardo said, right now we are providing disease awareness campaigns. We have app to help us to have questionnaires that the patients come up and give us all the results and all the effects that they are having with a certain treatment during their journey and treatment in their clinical trials. And in Brazil, we have this lack of patient association group events. And that's why we need this connection with the Way to My Heart, and will be much more important for us if you can help us in fostering association here in Brazil. Us as a clinical trial organization, we need that, and we have to know what the patients need to improve their adherence in a clinical trial, and much more to have the best treatment that they lack today. That's the part of Science Valley can help. Today we have all this social media to connect with our patients. And we just, right now, as much as we can have collaboration with your patient association group, we will certainly have more results here in our trials and for other ones.
And I believe Douglas has a quick question if he wants to unmute and jump in. Or I can ask it. He's wondering, as PAD patients, how do they know what trial is the right one for them as an individual?
Eduardo, do you want to answer that?
Well, Kim, they don't. We're improving that. It's very tough for our patients here in Brazil to have a matching like Tinder with the clinical trialist. We used to have an app who could map where our patients are and try to do this matching. But given that now we have this general rule of data protection via internet, it got very difficult. We're learning here how we can keep available to our patients what trials are we doing so they can find it online. Very rudimentary in Brazil. In the US is much better. If you type clinical trial in your disease, you're going to find which center in the US. And there's kind of questionnaires where you answer it and you can see where do you fit. So where people see sadness, we see opportunities. And we're kind of developing this kind of apps to help Brazilian patients find the correct trial.
And Dr. Bilar, yes?
Oh, sorry, because we are definitely convinced that the education of the general population is important, right? And that they can discuss with their physicians what the trials are available, if they have the characteristics of the population that would most benefit from that trial, right? So we really believe that education is very important.
Thank you. And Dr. Bilar, I just wanted to see if you would weigh in on the importance. He talked a lot about they're focused heavily on medical therapy or pharmaceutical therapy. And I'm curious, just in terms of your experience, the value of studies like these and what your questions are and what some of the gaps you're seeing in medical therapy and what you still want to know.
Yeah, absolutely. Eduardo, congratulations on doing what you're doing there. I would want to ask you a couple of things. I understand we are still evolving in our scientific data for peripheral arterial disease. And I agree with you that stenting is not the ultimate choice. We would have genetic therapy as well as the modifications and optimizing medical therapy, which is what you are currently doing. My question to you is how easy it is to have the studies, because all I saw was most of the studies are sponsored by American companies. They tend to come down to Brazil or South American countries for their studies. Is it because of ease of getting the patients, ease of enrolling the patients, and low cost? And second, is there any native difference between the pathology that you saw in US versus what you see down in Brazil? Because for us, I've noted that each ethnic group has a very different disease pattern, even though we call it PAD. So whatever the studies are there may have good results. We don't see similar results in our population. So if you could highlight some of those.
Yeah, two great questions. Well, initially we thought that American companies were coming to South America just because of costs. But to be sincere to you, we don't have much of the trials run here. Like if in the West we have 10,000 trials, we have 1,000 trials ongoing in Brazil. It's 10%. It's pretty much more expensive to run in the US, but on the other hand, the FDA requires to include a fair number of American patients because you pointed out there's difference between populations. But having said that, companies are sponsoring studies like mine here because they're very cheap. It's investigator-initiated research. The good thing is that the data belongs to me and it's totally independent. And I tend to invite well-versed colleagues from all over the world to check the data with me. And we publish positive results and we publish negative results, meaning I'm very academic. Having said that, Brazilians are getting a kind of Americanized. Caucasian Brazilians are getting very Americanized. We have obesity, hypertension, loads of diabetic patients, exactly like in the US. So Brazil population changed in the last 20 years. But we do have more diversity here, particularly because of the Asian population and basically because of the Black population. But still, these populations are totally underrepresented in global clinical trials. So there is an effort from companies and from academic institutions to have more variety in the trials everywhere, both academic studies and industry sponsored. So that's why we believe that South America will play a major role, such as India should play a major role, and such as China should play a major role as well, but with different challenges. Yeah, I think you have an Indian background. You understand what is the challenges to do a trial in India and what would be a challenge to do a trial in China. We're moving slowly, but two great questions, Dr. Ballard. Two great questions, and I think I answered you properly.
Thank you so much, Dr. Ramacciati, Camilla, and Leandro. And if you can, go ahead and put a link to your site in the chat. That would be amazing. We really appreciate you being here and sharing all of your great work. And we look forward to seeing those results of especially the last study coming up very, very soon, if you can send those to us.